Well, are you having a hysterectomy and you're not sure what type you want or what are the other options besides what your doctor offered you? Today, we're going to talk about the different types of hysterectomy, what they are, and why we choose one over the other. That sounds good to you? Continue watching. Well, I'm Dr. duPont. I'm a board-certified gynecologic oncologist, and I'm passionate about educating women on how to live longer and healthier lives, and I believe that begins with great health. Well, today we're going to talk about the hysterectomy. I'm going to go into some of the most common types of hysterectomy, just so that you know what is available, just in case you or someone you love will be having a hysterectomy soon. Well, one of the most common hysterectomies is a total abdominal hysterectomy. Now, when we're thinking about hysterectomy, all that means is that we're going to remove the uterine fundus and the cervix. And so that is a total abdominal hysterectomy. And that means that we take it out through the abdomen. Now, if we take the ovaries, which is called the oophorectomy, or fallopian tube, salpingectomy, doesn't change the hysterectomy. So whether we take the ovaries and tubes will depend on why you're having the surgery and then your age and then, what your doctor has counseled you about. But whether we take or leave the ovaries doesn't change the fact that we're doing a hysterectomy, removing the uterus and or the cervix. Well, when we think about an open hysterectomy, we can do that either through a midline or vertical incision or a transverse or phanicil incision, also known as a bikini cut incision. And so that will depend on, again, why you're having the surgery and your anatomy and what's the goal of the surgery. If you have cancer, most likely we're going to do a midline vertical incision. If maybe you just have fibroids or you're doing like a myomectomy, where you're not going to have a hysterectomy at all, we may do a phanicil or a transverse skin incision. So the skin incision is very separate, and it doesn't always determine what type of surgery we're going to do. But just so that you know that there's many different incisions that we can make. Well, in terms of the total abdominal hysterectomy, where we're removing the uterus and cervix, one of the great things about that procedure is that it gives us the best exposure. I'm able to see in the upper abdomen. I can look at the bowel, the gallbladder, the liver. I can look at the periotic lymph nodes, pelvic lymph nodes. So it gives me the most exposure. And so a lot of times for a patient with cancer, especially ovarian cancer, or someone that's having a cytoreductive or tumor debulking surgery, we'll do a open hysterectomy where we're doing that midline or vertical incision. Those are some of the advantages, is it gives us really great exposure to do surgery. And for some people like me that train to do a lot of open hysterectomies, I'm actually sometimes faster at the open hysterectomies than other kinds, just because I've done them for so long and I've done so many. But one of the great things, again, is the exposure. Now, some of the disadvantages of an open hysterectomy is, again, you have this big, huge incision. A lot of times you're in the operating room longer, so the surgery is longer. And because you have a large incision, you're more risk for having complications with that incision, whether it's infection, whether it's a dehiscence where that incision opens up, or a hernia formation. Let's say you get an area that doesn't heal properly and the area is weak, it may form a hernia. You also have increased risk of blood loss with an open hysterectomy. You're in the hospital longer. Your time off from work is longer because the recovery is longer. You do have more pain through those big, large incisions. And so there are a lot more complications to the open hysterectomy that may not be seen with some of the other types of hysterectomy. But just keep in mind, if we're doing an open hysterectomy through a midline incision or even a transverse incision, there's a reason for it. And your doctor will explain to you kind of why they chose this hysterectomy over another type. So another type of hysterectomy is a supracervical hysterectomy. And that's where we remove the uterine fundus, but we keep the cervix. So there's many different reasons to keep the cervix. And how we do a supracervical will depend on just what type of surgery your doctor has talked to you about. So we can do a supracervical through a laparoscope, or we can also do it open. Over the years, I've had a few patients that wanted to keep their cervix. Some people feel that it helps with sexual function. Some people think it may diminish the risk of pelvic organ prolapse after surgery. But just keep in mind, if you do keep your cervix, you do have to continue having pap smears, and because you can get, of course, cancer of the cervix. And then also, if you do keep your cervix, just keep in mind that if you're started on hormone replacement therapy, you may have cyclic bleeding. And that's because a small part of the top of the uterus or the lower part of the uterus is still attached, and it could have some endometrial tissue or lining of the uterus that may bleed. So over the years, I've had a few people, usually 1 or 2 per year, that had a supracervical hysterectomy for many different reasons, and they still have a cycle every month if their ovaries were left or if they start hormone replacement therapy. So just keep in mind that, keeping the cervix does have some risk and some benefits. Now, sometimes, over the years, I've had to do a supracervical because I couldn't get the cervix out. So usually if I'm leaving the cervix behind, it's because I couldn't get it out. Either someone had just a lot of cancer where it was like stuck and I just couldn't get it out safely, or someone had very severe endometriosis. A lot of times you'll get a lot of scarring between the lower uterine segment, the lower part of the uterus, and the bladder, where if you have so much scarring, it's not safe to remove it, or you're concerned about injuring the bladder. A lot of times we'll actually keep the cervix. So there's many different reasons. Just keep in mind that's called a supracervical hysterectomy. Some people will call it a partial or a subtotal hysterectomy, but usually it's called a supracervical hysterectomy. So the other type of hysterectomy that's very commonly done is a total vaginal hysterectomy. So that's where the uterus is taken out through the vagina. So the incision, you won't have a scar in your abdomen because all the work is done vaginally. And so that's a very common type of hysterectomy. It's more commonly done also if you have pelvic organ prolapse, because after you've done the hysterectomy, the doctor can do some other procedures to strengthen the pelvic floor. So whether they do an anterior colporphyry or anterior repair or posterior repair, or do a bladder sling to lift your bladder if you're having leakage when you cough, laugh, or sneeze. There's other procedures that we'll do at the time of the total vaginal hysterectomy that are commonly done and easily done because all their work is in the vagina. Now, some of the great things about the total vaginal hysterectomy is that it's less expensive. You don't need a lot of fancy tools or equipment, and it's very well-researched and well-studied procedure. So most GYN doctors are very comfortable doing a vaginal hysterectomy. Patients recover very quickly. They have less pain. They stay in the hospital usually just overnight, and they're back at their normal activities, their normal routines a lot faster because they don't have a lot of pain. They don't have the shoulder pain or the abdominal pain because there's no big incision. Everything is done vaginally. And so it's a really great procedure, especially if you've had pelvic organ prolapse. That's a great time to do some other ancillary procedures. Well, some of the disadvantages of a total vaginal hysterectomy is it does require an expert surgeon. You do have to have someone that's very skilled in doing it. The more skilled your surgeon is, the fewer complications you'll have, the less anesthetic time you'll have. So you do need someone that's skilled. And then again, another risk factor that may be a disadvantage for the total vaginal hysterectomy is that you can't have a big tumor, a big fibroid, or if you have like ovarian cancer, we're not going to treat that through a vaginal hysterectomy because we need to see the upper abdomen, we need to take lymph nodes, and you can't do any of that if someone's just having a vaginal hysterectomy. Another disadvantage of the vaginal hysterectomy is your anatomy. If you're someone that maybe has a very narrow or small pelvis and the doctor just can't get all their instruments in, it may just be too technically difficult, then you may not be offered a total vaginal hysterectomy. So another type of hysterectomy is a total laparoscopic hysterectomy. And I've got several great videos on this type of procedure. And so how this differs than the other ones is that you'll have some very small incisions. There's several different types of total laparoscopic hysterectomy. One is a single site laparoscopic hysterectomy where you just have one incision and the instruments are kind of angled and wristed so they can go in the abdomen, but it's very nice because patients only have one incision. You can do a robotic assisted hysterectomy or a robotic assisted laparoscopic hysterectomy, and that's very common these days. But you have to have a hospital that can actually afford the robot because they're very expensive. But that's another type of total laparoscopic hysterectomy using a very specific tool. And then there's a total laparoscopic hysterectomy that we call straight sticks laparoscopic surgery. And that's, easily done, very commonly done. Does require a lot more expense than the total vaginal hysterectomy, but it's a great procedure. You have very small incisions, and then the uterus, once the attachments are removed from the abdomen, it's actually taken out through the vagina. So what we do is we remove those support structures that are holding the uterus in place and slide it through the vagina and then close that opening in the vagina called the vaginal cup. So the total laparoscopic hysterectomy is really one of the more common ways we do hysterectomy in the United States, and it's a great type of procedure for most women. Now, some of the disadvantages of the total laparoscopic hysterectomy is that it may have longer operating room time and more cost, but that will depend too on your surgeon's skill. As we do more of these procedures, we get better at them, we get faster at them. So a lot of times, the time you're in the OR may not be as long in some of our skilled surgeons, but it is more expensive than the total vaginal hysterectomy and the total abdominal hysterectomy. Now, some of the other disadvantages, you may have some anesthetic complications because of how you're positioned. This procedure does require Trendelenburg, where your head is a little bit lower and your feet are up. So if you have respiratory problems like emphysema or COPD, you may not tolerate that as well, especially if you're morbidly obese. There are Also risks of injury, thermal injuries to the bowel, injuries to the ureters. There's also risk of infection of the small port sites. Not as common since incisions are small, but it can happen. Pelvic abscess, pelvic hematomas, pneumonias, vaginal cuff infections, risk of bleeding. There's also a risk of hernias in some of the larger port sites, not usually the smaller ones, but the larger ones. Risk of nerve injury. With any of the hysterectomies, you can have a risk of prolapse later. And that's, of course, multifactorial, but as we're detaching the uterus from the support structures over time, the vagina can get, say saggy vagina. So we do know that over time, the support structures will cause, the bladder to be a little bit saggy, the vagina to be saggy. So you may need surgery later for prolapse. And then there's also greater risk of urinary tract injuries with the laparoscopic hysterectomy. There's more thermal injuries. And again, there's more injuries in fistulas. Fistulas is where there's communication between two organs, and so that can happen a little bit more with the laparoscopic hysterectomy. But it is safe and it's very common, but the risk profile is a little bit different. But the nice thing about it is that women do have less pain. Typically they go home the same day, if not the next day, and then most women are back to their normal routine a lot faster than if they had a total abdominal hysterectomy. There is a little bit more risk of gas pain. Usually it's referred pain to the right shoulder, and that's from irritation of the CO2 gas to the upper abdomen. So those are some of the differences in the total laparoscopic hysterectomy. Now, another type of laparoscopic hysterectomy I did mention is a laparoscopic assisted vaginal hysterectomy. So in some patients where we can't do a traditional total vaginal hysterectomy, we may do what's called an LAVH, or laparoscopic assisted vaginal hysterectomy. I don't think it's done as much anymore, but it's a great tool that combines the vaginal hysterectomy with the laparoscope to be able to take down some of the support structures that's holding the uterus in place in the upper abdomen, and then you pull everything else down through the vagina. I learned to do that when I was a resident, and it was a really fun procedure, but it does increase cost and it does increase time in the OR, but it is another option of a type of hysterectomy. So it's called a laparoscopic assisted vaginal hysterectomy, or LAVH. And we talked about the supracervical hysterectomy. So the other type of hysterectomy that I want you to know about is the radical hysterectomy, or modified radical hysterectomy. Now, this is done typically for cervical cancer, but I have seen it done for endometriosis, especially with patients with very severe endometriosis, like stage 4 endometriosis. Now, what the radical hysterectomy does, it takes some of the support structures that are lateral, or not really support structures, but the ligaments lateral to the uterus. Instead of removing the uterus very close, we'll take some of the broad ligament that's lateral to the uterus, and we'll take that along with the hysterectomy specimen. So that's why it's commonly done for cancer of the cervix, to treat early cancer of the cervix. And so we'll take the uterus, we'll take the cervix. A lot of times we'll take the upper vagina. So we'll take more vaginal tissue and then more tissue around the uterus. So it's called a radical hysterectomy, and it can be done through the robot. Not as commonly done now, but definitely it's a more extensive procedure that has a little bit more nerve injury because we're taking the tissue around the uterus. So a lot of times the nerves will come through the broad ligament or the ligaments around the uterus, and so that does cause a little bit more nerve injury in terms of your bladder function and your bowel function. Mainly bladder is the thing we worry about the most, where your bladder may take a little bit longer to function as it normally had before surgery, just because of some of the nerve damage due to the extensive nature of the radical abdominal hysterectomy. But typically for doing a radical abdominal hysterectomy, you have a lot of, abnormal changes in the pelvis, and the doctor's having to take more tissue out to make sure that everything is removed. So the radical or modified radical, which is just a little bit less extensive than the radical, can also be done. So I'll also call like a type 5 hysterectomy, but I just want you to know that there is something called a radical hysterectomy, and typically that's done for cancer of the cervix, usually early stage cancer of the cervix. Well, regardless of the type of hysterectomy you have, the recovery is very similar. Certainly the radical you'll have a lot more risk of nerve damage, so you may have a Foley catheter that may stay in for a few days depending on why you had the surgery and how extensive your surgery was. And so I want you to make sure you know that. But typically once you recover, once you're out of the hospital, the restrictions are the same. Pelvic rest, no heavy lifting, no excessive bending or twisting. We do want you to walk every day because that reduces your risk of pneumonias, blood clots in your legs and in your lung, which are called pulmonary emboli. And so the more active you are, the better. The more you're up and walking, the quicker you recover. But typically, regardless of which hysterectomy, the instructions are very similar in terms of recovery. Typically, after your surgery, you'll see your doctor back 1 to 2 weeks to go over the pathology report and to look at your incisions to make sure you're doing well, check your vital signs, and then usually we'll see you back 4 to 6 weeks later after surgery to look at the top of the vagina or the vaginal cuff where that uterus was removed and the part that was sutured. And most of us will tell you, pelvic rest for at least 6 weeks. If you have a robotic surgery, it may be a little bit longer, but typically we want you to have pelvic rest. But depending on the type of hysterectomy, you may have gone back to work within that 6-week period. But for most patients, they do take off for about 6 weeks to recover. I hope that was helpful. Hope it wasn't too much information. So now you know all about the different types of hysterectomy. If you've had a hysterectomy that you had just a great outcome and you want to share with others, please put it in the comments below. Again, if you're new here and you've not subscribed, please click that subscribe button. That really helps them with the algorithm. And if you like this video, please give me a thumbs up so that I can continue making great content for you. And thank you for watching to the very, very end. And I'll see you in the next one. Goodbye.